All right, well, it's 8 o'clock. Welcome everybody to Medical Grand Rounds. We're delighted to have a special guest speaker today, Dr. Latesha Elopre. Introducing her will be Dr. Dave Andes, our Division Chief of Infectious Diseases.
My pleasure to introduce our first Grand Round speaker of 2023, Dr. Latesha Elopre. Dr. Elopre completed her medical degree at the University of Florida and then moved to the University of Alabama, where she completed a residency, infectious disease fellowship training, a master's in public health before joining their faculty in 2015. She's currently an associate professor in the Department of Medicine in the Division of Infectious Disease, and she also serves as the Assistant Dean for Medical Education, Diversity, and Inclusion. Dr. Elopre's clinical work, research, and leadership is in the area of health equity, especially as it relates to access to care in the prevention and treatment of HIV, where she's been really a national and international leader. And I'm excited to hear about her work. As you can see, her title is Improving PrEP Access to End the HIV Epidemic, Addressing PrEP Inequities. Thanks for your time, Latesha.
Thank you for the introduction. So I'm going to hop right in. This is some, I think, housekeeping in regards to how you can sign in. And these really are some of the most, I think, important conversations we can be having around the HIV epidemic. So I am so grateful to have the opportunity to speak today at Grand Rounds at University of Wisconsin. So I want to thank you for this opportunity. And first, give my disclosures. I do have some funding from Merck and some consultations and grants that have been awarded. So I want to provide some context first, just to understand why it's so important that we have these conversations and why it's so germane in the conversation around the HIV epidemic, specifically in the United States. And typically when we're talking about inequities, it's important to understand what that means. I love this illustration. It's based off the Giving Tree. For those of you who aren't familiar, this is one of my favorite books that I read to one of my children. And this illustration really shows the fact that when you're talking about what it means to have an inequity, if you have a tree that's leaning to one side, and we're talking about how do we make things right, how do we make things even, the idea of having something that is equitable is if you have one person that has access more so to one side of that tree, giving someone more opportunities, more ladders to reach the other side. And what I want you to pay attention to with this illustration, which I think is very purposeful, is that even though you're giving someone a taller ladder, because of the way that this tree has been formed over time with more fertile, more sun, more access to one side of this tree, you still have more apples coming to the person who had the advantage to begin with. And that is what we're seeing even with the HIV epidemic right now. So as it stands, we have all of the medical advancements necessary to end the epidemic. We have highly advanced antiretroviral therapies that, if taken daily, you can virally suppress someone to the point where they cannot transmit the virus to other people. We have antiretroviral therapies that if you do not have HIV and you take this medication, if you are exposed to HIV, will not contract the virus. But we're still seeing huge disparities and inequities in regards to who's getting HIV and the outcomes once they become infected. So you can see right now in the epidemic for the United States that Black Americans are the ones that are really carrying the burden of the epidemic primarily. And this is seen mostly among gay and bisexual men who have sex with men. Shortly following that, you'll see that this is primarily among persons of color. So you see Hispanic and Latino men who have sex with men. Then when you're looking at heterosexual transmission, Black women are sometimes, depending on where you're located, 12 times to 16 times more likely to be infected with HIV compared to their white counterparts. And so this has kind of changed the paradigm by which we have looked at how we can really change the epidemic. In regards to shifting our thought process, we're no longer looking at HIV alone, we're understanding that we have to look at it as a status neutral paradigm, in that we're looking at population health, and we're trying to understand from a community that's vulnerable to being diagnosed with HIV, where are those vulnerabilities lying, and how can we, number one, use HIV testing as a point to either engage someone into preventative care if they test negative, or if they test positive, quickly expedite them into treatment. And one of the means by which we're doing that is through a federally funded program called Ending the HIV Epidemic. Huge amounts of federal dollars have been poured into how can we, number one, increase and improve outcomes by 2025, where we have a decrease in HIV diagnoses up to 75% and then 90% by 2030. And I can tell you that the number one way to do that is by closing inequities that we're currently seeing in the epidemic. The one that I'm going to be focusing on today, and what my research really focuses on, is increasing PrEP access. And under this mandate, and what mathematicians are predicting, is that in order for us to reach these goals, we have to increase PrEP access among vulnerable populations by at least 50%. And there's really good evidence to support why this is necessary. There's been several great examples from a population standpoint where we've seen increases in uptake of PrEP that have directly correlated to decreases in HIV diagnoses. And that's when you control for those who are living with HIV who are virally suppressed. Within the United States alone, in places like San Francisco and Seattle, they're seeing huge reductions in their HIV rates by up to 50% just due to their huge increase in PrEP uptake. And some of this modeling has been done by Dr. Patrick Sullivan and others. The issue is that, especially in areas like the West and the South, we are not seeing those same gains. So right now, there's a prediction that about 1.2 million people would benefit from being prescribed PrEP. But we are not seeing that many people actually being prescribed PrEP. About 18% of persons who have an indication for PrEP are actually being prescribed. Only 10% of women and only 28% of men are being prescribed. And if you're looking at who those prescriptions are being written to, the vast majority are being written to white individuals. And there again are huge disparities in Black and Hispanic populations being prescribed. And we know that of this 1.2 million, over half likely would benefit from being prescribed who are persons of color. And this is only at the point where we're talking about looking at just PrEP uptake alone. If you were to actually look at each point, what we call the PrEP care continuum, so actually linking someone to PrEP care, prescribing PrEP, them starting PrEP, and then staying on PrEP care, these inequities persist at every step along the way. So this is something that was done with Kaiser Permanente data, where they showed that if you were to look at who actually is being prescribed PrEP, you see that it's primarily white individuals who are being prescribed PrEP in their cohort, and that Black individuals are less likely to also actually start taking PrEP once they've been prescribed, and they were more likely to discontinue PrEP and not have PrEP persistence within the cohort. And then I always like to show this data because I think it's so profound when you're talking about population health. So this is something that Patrick Sullivan presented at one of our international conferences in 2022, where he showed something called a PrEP to need ratio. And really what the PrEP to need ratio is telling you is that you're having an unmet need of PrEP being prescribed. So you're looking at the overall number of people who would benefit from being prescribed PrEP. And basically, if you're seeing high PrEP to need ratios, that means you're having really better rate of prescription. The lower the PrEP to need ratio, the higher the unmet need. And what you're seeing is that over time, we have seen gains, and you're looking at it regionally. In each one of these domains, the Midwest, Northeast, West, and South, there have been huge gains, but the highest gains have been in the Northwest. What's interesting is that even in the Northwest, where you've seen the highest gains, the inequities and disparities have persisted. So when we're talking about who's actually getting prescribed PrEP and looking at just the PrEP to need ratios, this white line, or purple line, sorry, is indicative white individuals who have a PrEP to need ratio. And you can see that there's this huge gap that's occurring where the PrEP to need ratio has improved for white individuals, but you have not seen that improvement for Black or Hispanic individuals, even in the Northeast, and that this has increased over time. And of course, PrEP to need ratios have been the worst in the South and in the Midwest. So what we saw in the beginning, where this groundbreaking data came out saying we're having an issue, only 1% of individuals who are Black are being prescribed PrEP compared to the 44% that we predict would benefit from being prescribed PrEP, has not improved over time. And this slide is just nailing that home. 2015, this first came out, which is now 7 years ago, and we haven't made gains in really the HIV epidemic in order for us to make our goals under the ending the HIV epidemic auspice. And then I want to just point out that, again, the geographical needs are pretty obvious when you're looking at it from which regions are being hit the hardest. And in the ending the HIV epidemic initiative, really, they've identified several areas that they've identified have the greatest need for resources because they have what they call hotspots, meaning that these are areas where they're seeing the hugest number of people who are being impacted by the epidemic. Our state, Alabama, has been identified as in the HIV epidemic hotspot, mostly for our rural epidemic. So in regards to Alabama specifically, I want to just highlight that this was an article that was in the New York Times, and it was actually about a young man in Mississippi. And I like to think that this is similar to what we were seeing in Alabama at the time, where really when you're talking about the population that is primarily being impacted and carrying the burden of the epidemic, is Black gay men. And in this article, they were talking about shining a spotlight on a hidden epidemic, something that no one had really been talking about, the fact that young Black gay men were still dying from HIV. And you see this young man standing on a road by himself, kind of carrying the weight of the epidemic alone. And even today, we got news that another young Black gay man in the state of Alabama at the age of 21 died of an HIV-related illness, who we just fast-tracked in our clinic to start on antiretroviral therapy. So these disparities still matter in a day and age where we've had huge medical advancements, again, that could end the epidemic if those were taken alone and not within the view of why are we not paying attention to some of the contextual barriers that we're seeing that actually lead to poor access. So just from a stance for Alabama, we are a non-Medicaid expansion state. We're one of 11, and we do, again, have the same reflective huge HIV disparities. And I want to just point out with this graphic, some of the biggest disparities that we see within our local epidemic is within our Black Belt. It's called the Black Belt because of the Black fertile soil. That is part of the historical context from, I think, most of the southern states, where you'll see that's where a lot of the slaves were being kept because that's where cotton was the most fertile to grow. And because of that, you see large swaths of Black individuals still living there and large amounts of poverty still in those areas. And usually within those areas like Lowndes County, you still see huge amounts of poverty, mass incarceration, poor education, and poor access to healthcare. And overlaying that, a lot of disparities when it comes to poor health outcomes. So what are barriers to utilization and implementation of PrEP? I think giving the context as to why we're seeing some of the inequities with PrEP, I've laid some of the groundwork as to why we're seeing barriers to utilization, but I want to share with you some of the work that I've done where we spoke to young Black gay men and Black women within the state of Alabama to speak to them specifically about PrEP access and why this has been something that we're not seeing huge gains in, specifically within Birmingham. So as a parallel, we've looked at this with HIV testing, and we know from HIV testing literature that lack of insurance coverage is one of the main reasons that people said that they did not access testing, especially Black individuals. They were concerned about high costs, especially for at-home testing, poor access to public transportation, and housing status. And again, things like mass incarceration, making it harder to access testing. And we're seeing some of the same parallels with PrEP. If you're looking at personal barriers and interpersonal barriers to accessing HIV and STI testing, the literature around that, things that have been uncovered are things related to homophobia and disclosure of sexual identity with HIV testing and accessing that, especially in public health settings, lower levels of education around the benefits of HIV testing and STI testing, discriminatory practices that are experienced at multiple levels, mental health and substance use, so syndemics that occur within communities that are highly impoverished, and healthcare mistrust. And so early on, when we started to try to talk about why we were seeing some of the barriers with PrEP access, some of the things that came out in early 2012, so this is right when PrEP was approved, was this idea that it was related to not necessarily the intersectional stigma solely with being Black, gay, and trying to access PrEP, but with HIV stigma and PrEP alone. So this idea of something called a Truvada whore came out, where if you were accessing PrEP, that meant that you were engaging in high-risk sexual activity. And then there was also the concern that there was low awareness around PrEP. What we've seen since then is that awareness around PrEP is actually largely increased. When you look at national survey data, you can actually see that most young gay men report that they have either seen an ad or they are aware in some way, shape, or form from their networks of what PrEP is, but we're still not seeing access and uptake of PrEP. And specifically among young Black gay men, a lot of the conversations are now focusing on things like intersecting identities and disparities that may be causing barriers to accessing PrEP, specifically within that Southeastern domain where I showed you the hotspots have been identified in the Ending the HIV Epidemic federal initiative. So for my work, this is our PrEP clinic. We have a university affiliated PrEP clinic that was started in 2014. And we want to understand specifically, right when we started our PrEP clinic, were we reaching populations that were most vulnerable to being diagnosed with PrEP? In this data, we looked at based off of who, from a demographic standpoint, we were providing care for in our PrEP clinic compared to who was being diagnosed in Jefferson County, which is the county in which our PrEP clinic sits. Are we seeing the same demographics of patients who are getting diagnosed with HIV? And what we found is that we weren't. This is one of the first papers that I put out in JADES that showed that we were seeing huge disparities in the number of people that were Black and gay that we were seeing within our clinic compared to the number of people who are being diagnosed within Jefferson County. So you can see at that time, 50% of our diagnoses in Jefferson County for HIV were among Black gay men, but only 18% of our patient population were Black gay men. And if you look at young Black gay men, which is the population at that time that was most likely to receive a diagnosis, only 8% of our patients were young Black gay men. So I would like to say that this has improved over time, but we still haven't seen proportionate gains in diversifying this pool, and largely because we haven't expanded Medicaid in our state. So you have to have insurance in order to access PrEP. So this is part of my career development award. I try to understand, outside of some of the contextual barriers related to poor access from health insurance, how could you look at intersectional stigma and some of the other levels that might impair or impact the ability to access PrEP? And specifically, I looked at it from an Anderson healthcare utilization model, looking at population characteristics and how that impacts health behavior. So I'm going to walk you through some in-depth interviews. We talked first, we did two sets. We talked to young Black gay men who had not accessed PrEP, who were not living with HIV. We talked about 25 men. We asked them, were you willing to use PrEP? Most majority said that they were willing, but only three were on PrEP at that time. And some of the major themes that came out is that there was a lot of stigma related to PrEP. So that was still true and blue, and a lot of medical distrust. So a lot of people still said, is this going to make me get HIV. There was low perceived need. So it was seen as a drastic step to take in order to prevent something that you didn't think you were at risk of getting. And I think that this is something that we're still working on in regards to public health, that most people do not think that they are at risk for getting HIV. And then in regards to their community, it was felt that there was a lot of silence in Black communities in the South, specifically around HIV prevention and sexual health. And I thought this quote was really powerful, where this individual talks about that the silence alone is what hurts the most. And this individual says, it kind of hurts us even more because we don't go to the health departments and get tested because we're afraid. And something that was really powerful is they talked to this idea about stigma related to this intersecting identity of being Black, gay, and living in the South. This individual talked about how they never had one true moment of peace in any sexual encounter they ever had in their life because of their identity. And they didn't feel that someone who was straight had to deal with that same type of stigma, and how it was felt that their sexual identity was a affront to their masculinity. The other thing that we pointed out with this paper is that while many people said that they were willing to take PrEP, when you actually talk to them about taking PrEP, they really were not willing to take PrEP. It was not right now. I don't think this is for me. And then one person even said, I hate PrEP in later on in the transcript. So I think that the idea of trying to understand more proximally how can we improve things related to acceptance of sexual identity and sexual health overall came out with this paper and with some of this foundational work. And so we did a deeper dive trying to understand what really led to acceptance of sexual identity, and understood and looked at things like internalized homophobia. How can we understand and look at social support networks and what that actually looks like? And then understand and explore cultural norms within the Black community. And what we found is that networks were actually more diverse than what we imagined, and especially through the journey of acceptance of sexual identity, where a lot of young Black gay men talked about the first person they came out to was actually a Black woman. So the second set of interviews that we did, which was a little gut-wrenching, is we talked to young Black gay men who were newly diagnosed with HIV. They were diagnosed within the last year. And we asked them, so you were recently diagnosed, can you tell us why you didn't access HIV? And this was published in 2020. So this is after PrEP had been out for a little bit. Again, we did it with relatively young Black gay men, and the same themes popped up: HIV stigma, homonegativity, and this idea of not being able to be open about your sexual identity. They also talked about having low PrEP knowledge. So they didn't know what PrEP was or who PrEP was for. And they didn't know how to receive it. So there was this idea that even though they were aware of PrEP, again, over 80% of men right now who identify as being gay and bisexual are now reporting, I'm aware of PrEP. They didn't know, does insurance cover it? What are the side effects? They wanted more information before they took, again, this drastic step to actually take something that, if you're otherwise healthy, why would you take? And no one felt that they were at risk for HIV. And again, these are men who were newly diagnosed with HIV. And it's because of how HIV was discussed with them. Most of the men report they were with one partner at the time, and it was a trusted partner. And some men discussed the idea of being young and feeling like they were invincible. So when we asked them, how do we increase knowledge and interest around PrEP? They said that we had to reduce stigma and stop only targeting Black gay men, meaning that, and I thought this was powerful, they said that the only time you see young Black gay men on TV is if it's for an HIV or PrEP commercial. You never see them otherwise. So it makes it feel like there's so much stigma around being Black and gay. We also did some quantitative surveys with Black gay men to understand how these same themes related on a more generalizable scale. And we did this with about 300 young Black gay men within Birmingham, and put some of the same validated scales that looked at things like religiosity, looked at social support systems, and tried to quantify it. So you can see here that some of the things that I thought was really interesting is that social support was actually predictive of PrEP use. So it did matter. Sexual stigma was important. Provider trust was important. And then things like healthcare stigma also was important. And so after that, I thought to myself, going back, trying to understand how all of these things fit together, from the in-depth interviews, from the quantitative surveys that we've done, if we can actually conceptualize what really matters in regards to access and engagement in PrEP care, from a model standpoint, we have to improve information and knowledge around PrEP and not just awareness. We have to tap into social support and the systems that are already in place within Black communities, and then focus on some behavioral skills in regards to dealing and understanding strategies to abate some of the environments that are a lot of times toxic for Black gay men to encounter on a daily basis. And so right now we are doing an intervention where we're trying to improve social capital among Black gay men in order to access PrEP. And we're trying to do that through the bonds that they already have within their own social networks, and in putting into those bonds some leveraging with bridging capital, introducing Black women from community-based organizations to see if they can have new information brought in, and potentially from a trusted individual that is not already within their network. And one of the examples that I like to give when I give this talk of social capital is the civil rights movement. The idea of you having a network in place, you're getting hit with something, for instance, like the Montgomery boycott, where you have to leverage shared resources in order to meet a goal. So in this instance, if you are not accessing public transportation, because this essentially broke public transportation, what do you do in order for you to be able to get to work, in order for you to be able to feed your family? You're tapping into your network and you're using and sharing shared resources to meet a goal and potentially, hopefully, transform, in this instance, a public health injustice. So specifically for this intervention, the thing that we're trying to do is do this in an app space. And this is information related to HIV knowledge, PrEP knowledge, motivation that focuses on resilience and understanding HIV risk due to prevalence, not behavior, because there's strong evidence to support that just related to your zip code and where you live. That's one of the biggest predictors of whether you get HIV, and then focus on behavioral skills. And we're doing this in a virtual space. So we're doing this with an app. And these are the topics that we're using it for, and the recruitment that we're going to be doing it for. And so specifically with young Black gay men, I've changed my image of this man, where in the beginning, I kind of looked at him and I felt bad because I felt like he was isolated. But now I'm trying to understand what allowed him to be strong enough to stand on that road by himself. It's still an injustice that he has to stand there alone, but the fact that he's brave enough and strong enough to, what can we do to understand and leverage some of that strength, and hopefully improve access by strengthening Black communities, and then strengthening it also with Black women. So I have repeatedly given this talk and talked to other community-based organizations, and they said you can't end the epidemic if you don't pay attention to the communities in which it's impacted, which includes all people within that community. And so this illustration is showing you again that we're still seeing inequities among Black women. And if you're looking at PrEP uptake and access, some of the biggest inequities we're seeing is among uptake among women. Women are not using PrEP. So only 7% of prescriptions in 2018 were written for women. We did another set of interviews with women, and I was really excited about this set because this was in the Black Belt. So we did a set in Birmingham. This is what Birmingham looks like. We did a set in Montgomery. This is our other huge city. But then we did focus groups in rural counties. And these are some of the most hard-hit rural counties. This is Lowndes County. This county became famous because of a septic issue where they were literally having waste going into their water systems. We did it in Wilcox, which has poverty rate in the 10th highest percentile in the United States. a median household income of about $24,000. We did it in Selma, Alabama. And we did it in Macon, which is Tuskegee. So I was really excited that we got to do interviews in these areas. We talked to women in churches and had people unlocking their doors late at night to let us into their homes. And some of the major things that we looked at was, number one, what were barriers, again, to accessing and talking about sexual health and PrEP among Black women? But also, we did something called discrete choice experiments with this, trying to understand, if you were to access PrEP, what would you want that service delivery platform to look like? And so some of the major things that we found among both groups is that for women, they said, we don't have a lot of knowledge around HIV. And when I say that there was a lot of low knowledge around HIV, there was also a lot of stigmatizing knowledge around HIV. So a lot of misinformation still around how you get HIV, thinking that you had to change silverware, thinking that you could still get it from Band-Aids. Like, it was really bad that we hadn't done a good job in regards to education within our state around how HIV is contracted. Low perceived need for PrEP, again, lack of education around PrEP. So low awareness about what PrEP was still prevalent among women specifically. And they talked about multiple structural barriers. A lot of HIV stigma, specifically around the urban women, and then the rural women were very afraid of accessing PrEP within a rural community. When they talked about what attributes would be important in regards to looking at PrEP, they really talked about things like what kind of provider they would get it from, where they could get it from, how and what the medication would look like, and how often they would have to come in to receive PrEP. And so we use that in our discrete choice experiment. And with this model for discrete choice experiments, is essentially kind of like using behavioral economics and using it for a healthcare setting. So if you were to think about it from a Pepsi can standpoint, for a Pepsi product, discrete choice experiments is telling you what color should the Pepsi can be, how much should it cost, where should it sit on the shelf in the grocery store, and in which grocery store should it sit. You're using that for a healthcare setting. And so for this, we looked at things like, where should you receive PrEP, at family planning clinic, STD clinic, telehealth, what kind of professional should you get it from, OB-GYN, pharmacist, general practitioner, how would you receive it, what type of pill, long-acting shot or implant would you receive, and then how frequent would your visits be? And then you choose which package you think is most attractive with the survey. So this is some of the responses that were received in regards to who was willing to use PrEP. The majority said that they were not willing. Some said they did not know. And then a small percentage said, yes, they'd be willing to use PrEP. This is the median age of our women, which I thought reflected nicely with the HIV epidemic. We looked at things again like religiosity, but we also looked at interpersonal and reported violence against women. We looked at social support, we looked at HIV knowledge, number of sex partners, and we actually looked at CDC indication for PrEP. And so what you can see here, which I hope is reflecting well on your screen, is that amazingly, a lot of women said they did not at all want to receive PrEP at an STD clinic. They did not want to receive it at a family planning clinic. A very small few said they would go there, but most wanted to go to their doctor's office. And when you looked at who they want to receive it from at the doctor's office, it was from an OB-GYN. So not from an ID doctor, which I was a little sad about, but I thought it made sense. And a lot of people were very interested in long-acting and pills. We also did latent class analysis with this to figure out were there certain groups that fell out based off of what preferences they had. And we did see there were about 5 groups that came out, and the group that had the largest rural number of women, this is not showing up as well as I would like, actually really preferred to have the long acting and had more preference for telehealth. So we're doing one aspect of research related to this data. It's called PrEP for Her, where we're trying to integrate PrEP into GYN clinics. We're doing this as a pilot study right now to see if we can come up with some implementation strategies to make it easier to prescribe PrEP into a GYN space. And we're starting first with just understanding what sexual health looks like within GYN clinics and taking sexual histories within GYN clinics. So going back to this comprehensive status neutral continuum, I think that really the other important part to realize with this that I've said multiple times, that this requires us to really talk about sexual health, and comprehensive sexual health care is necessary in order for us to reach an end to the epidemic. And something that I would love to imagine, one day I'll write a grant about this and it'll get funded, is actually doing this in school systems, because this is what's really going to be necessary in order for us to end the epidemic, for us to reach and talk to young girls, young boys about sexual health at an individual level, then being able to talk to their teachers and counselors, and being able to talk about things like STI and HIV testing within schools, and receiving PrEP navigation within school settings. So again, back to this idea of intersectional and stigma and intersecting disparities. These exist for every population that we see. They exist for Black gay men, for women, for trans individuals, for transgender women. We have to understand and be able to access and create interventions that reach and speak to all of these individuals for us to end the epidemic. And I want to close with some really cool science, because I think that's always the best way to close. So PrEP care does mean comprehensive care. This is one study that was done. Ken Mayer's group did this, that showed that, number one, if you actually provide mental health services, they were able to see you actually had greater retention in PrEP care. So this really showed that in a setting where for a lot of us, we are only offering PrEP, we do not provide primary care or other comprehensive services like we do for our HIV patients. If we did, we actually would likely see higher persistence in care. This study speaks to the purview paradox, which I think is interesting, because in our study that we did, it showed that women want to receive PrEP care from their OB-GYNs. So if you talk to who should prescribe PrEP, you talk to primary care providers, you talk to HIV providers. HIV providers say, you shouldn't get it from us because this is something that should really be done in a primary care setting. Primary care providers oftentimes don't feel comfortable prescribing PrEP. If you were to ask patients again what they would like, a lot of times they don't want to go to an HIV care provider to get PrEP because of the stigma related with HIV. So this study actually looked at primary care providers and looked at primary care providers who are prescribing PrEP, almost 100. And what it showed is that the more you were used to and comfortable in talking about sexual health with your patients, the more likely you were going to prescribe PrEP. It was a small sample size, but I think that it speaks to the importance of us teaching and understanding how to take a good sexual history. And then this retrospective study, really, number one, systematic review, showed that the biggest barrier that they found when they were looking at accessing PrEP, still, lo and behold, is insurance. Lack of insurance is the number one barrier for PrEP utilization. And I can't speak enough to this, especially, again, being in a state that hasn't expanded Medicaid. The only way that we're going to move forward with the epidemic and with a lot of injustices we're facing in regards to disparities we're seeing in other disease states is through access to equitable healthcare. And so this was really profound. It looked at not only quantitative, but in-depth interviews as well. And insurance was the really unifying theme that came out. There's also some calling for injustices related to what has been approved in regards to modalities to deliver PrEP. So we have really moved forward the needle in regards to how we deliver PrEP and options that are available. For men right now, we have long-acting PrEP in the form of injectables, and we have an oral pill. The vaginal ring is something that was controversial in that it is approved not here because there was questionable efficacy. And this paper called into question whether this was a reproductive injustice, not having this available within our states. And then just closing out with the fact that access still matters. So again, this is a cluster. So within our state recently, we had 2 cluster outbreaks, one in Lauderdale County and one in Coosa County. One was 22 cases, and we know from surveillance data and from doing genotyping that these cases were all related. If you were to look at prepme.org at these 2 locales, you can see that both of them are completely PrEP deserts, meaning that for these individuals who tested positive for HIV, if you were to look at their sexual contacts, and what really should happen again with this status neutral approach is that you refer them to PrEP services who are not living with HIV, you would not be able to offer them that service because there's no PrEP providers within their location. Some potential ways forward: we have to fix our PrEP messaging. We can't continue to talk about PrEP messaging in the box of risk, because that will not continue to work. And this really is, again, driving that home. This study is looking at how we can increase the idea of talking about PrEP as a means to improve pleasure around sex. Using more patient-centered approaches in our research. So using community engaged research, I think the best example of that was with the COVID pandemic and what we did with our clinical trials, using methods like discrete choice experiments and implementation science. And changing some of our models for PrEP care. So having culturally sensitive and aware and appropriate services is always going to be center and necessary for us to access and reach vulnerable communities. And then trying to think outside the box. Are there ways that we can move to reach communities when they can't come to us? So doing things like telehealth, having mobile vans and mobile clinics, or doing innovative things like at-home PrEP, where PrEP is delivered to your home. And we have to keep, again, moving the needle forward with medical innovations. So I think long-acting PrEP is something that's amazing, and it was actually shown to be superior than oral PrEP. This is the idea of you being able to get a shot and you're protected for 8 weeks. But again, if you can't afford PrEP, you don't have insurance, you don't have the means to come to the clinic, this could potentially widen the disparities that we're seeing and in itself become an inequity. So to close, really to end the epidemic, it's going to require us to not just look at this from an equity standpoint. We have to look at it from a social justice standpoint. We have to actually right the tree so that there are the same number of apples growing on each side. And that's the only way, I think, for all of the disparities that we're seeing in regards to health within our country, we're going to see a change. So I'm going to end it there and open it up for questions. I want to thank everybody, especially all the people and mentors that I've been able to work with. It's been a pleasure, and I appreciate you allowing me to speak today at Grand Rounds.
Thanks so much, Dr. Elopre. It's really eye-opening to see and understand better some of these barriers. I was surprised also to see, and I guess maybe disappointed to see the OB-GYN preference for women as far as who they want to prescribe. What percentage, I guess, both in the OB-GYN population and in the primary care population, what percentage of PrEP is prescribed? Do we know?
So I can speak locally right now. We have no OB-GYNs who are prescribing PrEP.
So you just wonder if it should be part of our, just like we are with the injection drug use epidemic, and incorporating this more into our education programs for these other subspecialties.
Yeah, and I was going to follow up on that, because it seemed like a big deficit is provider comfort at, doing the sexual health history and discussions. So are you planning to develop some training educational material for primary care and or OBGYN to have these discussions?
Yes. So we are, as a part of this research, doing some key informant interviews, and we have CABs where we're developing a sexual history taking toolkit to make it easier to take a sexual history and to do it quickly and hopefully in a way that is comfortable for that setting. I think that's one of the hardest parts from a workflow standpoint for them, is incorporating it into what they routinely do. And from my understanding, for our clinic, it's not something that's routinely done where they're stopping to take a sexual history. The other thing that was a huge barrier is we have to do every 3-month testing. So we don't routinely do HIV testing every 3 months in a GYN setting. So that's something that we're going to have to incorporate as well.
How much do you think, while I would agree that it seems that best practice is this every 3 months, how much do you think that is actually a barrier on the patient side?
I think it's a huge barrier. And I don't think it's something that's necessary, specifically, especially for some of our oral regimens. So we have discussed moving away from that and trying to do like a 6-month model. And I know there's some clinics that are doing that, especially now that they're recommending doing lab-based testing, which is even bigger barrier. So a lot of clinics were doing rapid testing, which was like a finger stick or an oral swab, which is a lot of times easier for patients to do. But with the new guidelines, they're recommending viral loads be done because there's concern of resistance. So I do think that's a barrier.
Yeah, and that's one of the questions actually in the chat area here, wondering about, is there monitoring for frequency of resistance mutations over time in the PrEP population? And the person sort of framed 3 scenarios that they made analogies to antibacterial resistance, people sharing medications, unknowingly infected people on PrEP, things like that. So how common, do we know how common resistance occurs in the PrEP setting, and what are people doing to look at that area?
So if you're providing PrEP, one of the mainstays for providing PrEP care is to try to support PrEP adherence, because we do, and we want to make sure we prevent PrEP resistance, because this is one of the cornerstones for a lot of our antiretroviral therapy for people who are diagnosed with HIV. However, I will say that we have wonderful and such an array of HIV medications now that if a mutation did occur, it would not prevent you from allowing a 1-day, 1-pill option for someone who becomes infected. So I don't think that resistance should be a barrier to prescribing PrEP. In saying that, what they do recommend is that in order for you to shorten the gap to diagnose somebody, if they become acutely infected, is that you check a viral load. Typically, we don't have a way to screen for adherence. There are some tests that are trying to come out to become commercial, where you can check things like urine to see if people are actually taking their medications. But in all reality, we don't really do that with a lot of medications that we prescribe, where we're checking people's urine to see if they're taking their blood pressure medication. So I don't think that we have to do that in the PrEP setting. I think we just need to counsel and make sure that people are aware that it's important to take it. And for anal exposure, so if you're talking about how much PrEP you have to take to prevent an HIV infection, you really don't have to take it 4 times out of a week. So it's not a lot. For vaginal exposure, it's really every day. So 6 times out of the 7 days in a week, you have to take it. So that's why there's so much push, I think, to try to find more long-acting options, especially for vaginal exposure, because you're just not getting that protection with oral options for women.
I wasn't aware of that. That's surprising to me. Is it a pharmacokinetic reason?
Yeah.
Or okay?
It's pharmacokinetic.
Some really great practical questions in the chat here. So one, as you mentioned, cost. How much does PrEP cost?
It's expensive. Okay, so, and this is it's a complex question. So TDF FTC, generic Truvada, is actually pretty cheap now. It's generic. And the reason why it's a complex question is because a lot of clinics right now function off of getting rebates related to the medication itself, and that rebate helps pay for people who are underinsured or uninsured. So if you were to prescribe brand Truvada, you were to prescribe Descovy, or you were to prescribe cabotegravir. Cabotegravir, which is our long-acting, is about $20,000 a year.
So that's the 340B type of, yeah. So another great question. An underserved area is the intersection of the HIV and opioid use disorder group. What recommendations do you have for increasing PrEP in that area?
So there's been a lot of great work looking at how to have more PrEP prescription within substance use disorder clinics, so in rehab facilities. I think that some people have felt like the requirement to check a viral load has been a barrier for that setting, but I think people are moving against that, and they're doing rapid testing in that setting. So that's one thing people have done, actually put PrEP clinics within rehab clinics, and I think it's been wildly successful. Something else is within some of the clinics in San Francisco where they do like needle exchange programs, they'll actually give PrEP starter packs. So really, I think some inventive ways to increase PrEP access among people who have substance use disorders.
And then another question about a setting-based question, and that is work in faith-based community to engage individuals in PrEP. Is that effective given stigmas and things like that?
It's also a great question. So there has been some work looking at partnering with faith-based communities. So I will say from the work that I've done, it's population specific. So for Black women, they were very keen on working with faith-based organizations to access and discuss PrEP. I think that there's a lot of, I think we would have to understand the dogma related to some of the sexual health discussions within that setting, and whether there would be openness about talking about PrEP in that location. So I've gone to churches and given talks about PrEP with ministers, and it's been very interesting. Some have been very polarized in their beliefs about PrEP and whether this was an appropriate place to discuss it. And some have been very open, thinking that this is the perfect place to discuss it. So I think it's a great idea. I don't know if you would get broad uptake of it.
And then a question about tying provider compensation to, so PrEP, using PrEP and PrEP education as a tie to provider compensation to move the needle. I don't know what your thoughts are on that. I'm not sure that's.
Maybe I will rephrase that and maybe, taking sexual history as a quality metric for some, accountable care places, value-based care.
That's a fantastic idea. And I think that there's a lot of models where we've already moved the needle and done that with other. So yeah, that's fantastic.
Are there efforts to do that you're aware of, or?
No, not that I'm aware of.
Yep. It's an opportunity for us.
An opportunity.
Well, and I'm wondering, so we we were funded by the AMA to start the first LGBTQ fellowship here to address the needs of our communities. And I don't know if Betsy's here or not, but it would be great to talk about a project for one of our fellows in that area, because it seems to make a lot of sense.
And that's fantastic.
And then we have go ahead, Lynn, sorry.
I was going to say there's a great call out for the Midwest AIDS Training and Education Center here available and for our primary care docs to get some additional support. Thank you, Sarah, for mentioning that, because they're based, we have them here at University of Wisconsin. I know, Dave, if you want to mention anything else about it.
No, absolutely. Something we should get in vital signs and get the information out to people, given how compelling Dr. Elopre's presentation is. It'll be top of mind for sure for a while.
Well, maybe we can collaborate with Dr. Elopre and come up with a project to try to increase education here.
I would love to. I'm very passionate about this. I hope that was conveyed. I just think it's so important.
Great. Let's see any other.
And maybe I'll ask while Dave's trying, one of the things I was thinking about as you were talking is there are many areas, well, two things. One, AIDS is not just a US epidemic, it's a global epidemic. And do you want, can you address what the uptake of PrEP is globally and what the barriers are? Because I think they're different.
They're very different. When I go to international conferences, it's always actually kind of a hoot, as I like to say sometimes, because they'll say to me, "You mean insurance is the barrier?" What are you talking about? So it's a very different conversation. They still have gaps in regards to coverage, so I don't want to make it seem like PrEP is available for all. Obviously, there's huge barriers for access, especially in Africa, but the barriers are very different. And I think a lot of them more so have to do with local governmental policies and laws, but especially when you're talking about places like France, and the conversations around insurance being a barrier is not one that they bump into.
I see a question here about the availability of, I guess it would be non-pharmacologic preventative options like condoms and things like that, the relative effectiveness of those and availability of those.
Condoms, depending on using them correctly, are highly effective. I think that, the issue is that we've had condoms around for a very long time, and we still haven't seen movement in regards to that being a sole intervention that's going to end the epidemic. So we always package our PrEP and sexual health toolkits with condoms and lubricant, because you should you should have that comprehensive sexual health packet and talk about all ways to prevent sexual health, sexually transmitted infections, because PrEP is not going to prevent syphilis, gonorrhea, chlamydia, or trich.
And then one last question regarding the disparities in studies looking specifically at transgender women.
So there is huge disparities in regards to transgender women. And the issue is that we don't do a good job from a public health standpoint of capturing that systematically, because we don't capture that data systematically on understanding gender identity. So we can glimpse it from a lot of cohort data, some of the inequities that occur with trans populations, specifically transgender women, not as much with trans masculine populations. But yes, transgender women have some of the hugest inequities when in regards to HIV rates and low access to PrEP. I think that there's a movement to try to, in regards to understanding how to improve and access PrEP for that population, really have more specialized focus, because again, that context is just so important when you're talking about some of the endemics that are involved with transgender women, especially violence and some discrimination that they face.
Well, we are just about at the hour. I really want to thank you for an eye-opening, depressing yet hopeful presentation. I think there's many opportunities for us to improve the healthcare that we deliver, particularly to many of our underrepresented populations and disadvantaged populations, and that we are obligated to do a better job of it. Love to have you come back in the future and show how we've moved the needle.
I really hope. I'm very hopeful. And this talk can be sometimes depressing. I don't want it to be that way, because I think we should always be hopeful. We don't believe that we can change things, then they won't change. So
Yes, no, I totally agree. I think you've also shown there's lots of opportunities in bringing a science to understanding what the barriers are, and then how do we develop interventions to overcome those barriers is the key. So thank you. We'll have you out again for ice fishing. We'll make sure you've got the right clothing and prep work.
Thank you. Thank you.
All right. Thank you. Thank you, Dr. Andes, and thank everyone. Take care.
Thank you. Take care.
Take care.